Good morning. Welcome to the Berrien County Board of Health meeting. I'd like to call this meeting to order. And as you make a motion, as you second, if you'll please let us know who you are, so that would make it easy for the note taking. So the minutes of the May 6th meeting, may I have a motion for their approval?
So moved.
Edwards.
Okay, Edwards moved. Is
Second.
there any second?
Vanessa.
Linda, did you second?
Vanessa.
Vanessa, sorry, Vanessa. Okay, Vanessa second. Any discussion? All those in favor?
Aye.
Opposed?
Aye.
Okay,
Aye.
Aye.
right. So the motion carries. Moving on to vouchers, we were able to see the vouchers in the packet that went out to the Board of Health. Lisa, anything unusual in the packet?
The only significant amount that was in there is a return of some Medicaid cost-based reimbursement. The amount was $25,420. And it's a true up of a 2018 Medicaid cost reimbursement calculation. So this is the final adjustment coming through on that.
Right, thank you. So may I have a motion for approval of the vouchers?
Ray moves for the approval.
Linda seconds.
Discussion? All those in favor?
Aye.
Opposed? Motion carried. Do we have one resolution or more than one resolution? I see the United Way fund acceptance.
Just the one. So I'm going to have Jillian walk us through the scope. Can you all hear me from if I'm sitting back here still?
Yep.
Okay.
Yes.
So this is just a really simple resolution. We were contacted by the United Way, the Healthy Berrien's director, a few weeks ago, and they said, you know, as they're looking at the rest of their funding for this year, they identified a small bit that was not going to be able to be used for a project previously identified, and they reached out and offered it up to go to the Benton Harbor Farmers Market, which, as you know, is always looking for a little bit more funds to help support operations. So we were happy to accept that money, and if you choose, we would love to have you endorse the resolution to formally accept that and add it to our contract with United Way.
Are there any special things this will allow us to do?
So as I had indicated last month at the board meeting, we are operating the market this year. It is going to be a pared down season with a reduced number of weeks for operations. And we are really limiting the amount of activities that are going to be occurring there. It is strictly going to be about buying fresh produce. There will not be any cooking demonstrations. There will not be any extra kids activities or Zumba. You know, really in an effort to reduce the potential for people to be gathering. It is strictly going to be about buying fruits and vegetables, being able to use the food assistance benefits that people have. And, you know, there's a lot of things that we've put into place to encourage social distancing in the market. We've been making plans about spacing tables apart and, you know, having a traffic pattern flow throughout the market. So it is going to be reduced in its scope and size. That saddens us, and you know, we're just looking forward to next year and hopefully the market season of 2021 being able to kind of get back to some of the more enhanced activities and robust placemaking that we know really added so much value to the market.
Really ran a quality market. It's a shame, but certainly understandable. All right, you have the resolution in front of you. May I have a motion for approval?
Edwards moves to approve.
Edwards approve. Is there a second?
Linda Stroll seconds.
Okay, Linda, second. Is there any discussion of this resolution? All right. All those in favor?
Aye.
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 Opposed? Okay, motion carried. Thank you. I just want to say thank you again for continuing with the Benton Harbor Farmers Market. It's close to my heart and I think it's really important for people. So thank you. I know on top of everything that you've really had a run here and to keep this going, just really, really appreciate it. So, and just generally appreciate the staff for the many hours you've put in. It just seems like nonstop. We care about you. We care about your health and the health of your families, and just hope that you'll care for yourselves as well. So,
Yeah.
all right. And speaking of great staff, we have some recognitions. Woohoo! I wish I could shake your hands, but I don't think I'll ever be able to shake your hands in the future. So, who is going to lead the discussion of these wonderful people who have supported the department with so many years? We really appreciate it.
So I'll go ahead and get us started. So the first staff member that we're going to recognize is Melissa Jordan. She's having her 5-year anniversary with us at the health department. I believe, Melissa, you had a little bit of extra time before that might not have counted officially towards the clock. Oh, you're on mute, Melissa.
Sorry, can you repeat that?
Just saying, I think you worked for us for a while as a temp sub before this clock started. So you've really had more than 5 years of service with us. But I'm gonna have Dawn, who's Melissa's supervisor, say a few words recognizing Melissa's anniversary.
Good morning. Can you hear me okay?
Yep.
Yes.
Good morning. Yeah, Melissa started with us in, I believe, 2012 in the fall and kind of got thrown right into training. And not only has she been a strong asset for the hearing and vision program, but we advocated to get her from a temp sub position to a part-time position, and then advocated for her to become full-time, which I believe was 2018. Is that correct, Melissa?
Yes.
Okay. So she's been, I think it was in the August when she became full-time. So it'll be 2 years full-time, but she has been with us since 2012. She not only is an asset to the hearing and vision program, but she is an asset to the health department all around. She's always willing to pitch in, cover programs, and do whatever is needed to get the job done. She is our, as she would call herself, computer geek. Whenever we have anything that we need done, I always turn to her. So she's a big supporter for me as far as getting things done on the computer. And thanks for being here, Melissa. You're appreciated.
Yeah, and just from my perspective, this is Nikki. I mean, Melissa's always somebody who's willing to jump in if there's help needed with some sort of department-wide initiative or filling in with another program. Melissa is more than willing to help however she can. She really believes in our mission. She wants to help and serve our community and do it well. Melissa, we appreciate your diligence. We see all of those efforts you put forward. For those of you who might not recognize the background behind Melissa, she's actually sitting by our front door doing some staff screenings right now as people are coming into the facility. She has been instrumental in helping us as we've really adapted, very flexible. We just so appreciate all of the efforts that you put into, and BCHD is just, we're really grateful to have you, Melissa. Thank you.
Thank you. Thank you all.
We'll get you your certificate in a contactless method so that you
Sounds like good.
Thanks for not staying in a silo. I think that's the mark of someone who has a great deal of excellence. So appreciate it.
I really do love my job. I can say that.
That's great. Thank you, Melissa.
Thanks, Melissa.
Thank you.
So next up, we have John Gruchot, who made 25 years with the county. And if I'm remembering correct, this is almost 5 years with the health department, correct?
Yeah, just a little shy, September.
Yep. So I'm going to turn it to Nick to offer some words about John.
Be gentle, Nick.
Nick, you need to come off mute, please.
He's looking for it.
Nick, you're on mute. I can't help you.
Bottom left corner, Nick.
There, he's off mute.
Well, so past these little few technical difficulties, thank you, Dr. J. Touchdown. All right. No, yeah, John is celebrating 25 years with the county and almost 5 years with the health department. He's been a valuable member of our food team. He's always pitched in whenever asked and needed extra help, and we truly appreciate that part. John has had, for the last 5 years, has had the pleasure and sometimes displeasure of serving the southwest part of the county away from the office, traveling through the winter storms and the snow and the rains and all that kind of stuff down 94. All the way from Benton Harbor, St. Joe to New Buffalo and Galeen Township, and he's helped out the rest of the county.
Center of the universe, you mean?
Jeez, come on, all the way.
All the way.
Even though I live down that
Every
way too,
day.
so no, it's been great. He's done a wonderful job with the restaurant inspections and plan reviews. He's been trained into doing plan reviews also for change of ownerships and modifications in restaurants and opening up brand new restaurants. So we truly appreciate all his help and everything that he has contributed so far. And I know for a lot longer to the health department, environmental health in the food program. And he's also, trying to get cross-trained in some of the other areas as far as pool inspections and campgrounds and some of that other stuff that in the past has been kind of reserved for or more compartmentalized between the two different teams in environmental health. So it's great to have somebody that is willing to jump in and help in whatever way we need. So thanks, John. Appreciate it. All your help.
Thank you, Nick. Appreciate it.
Yeah, and I'll just add to that. I mean, John, when John started with us in the food program, we were just starting to go through a bit of upheaval in that program and some turnover after some really long-standing staff had retired, and then we had some other turnover with staff who were with us for a year or two and then continued on. And John has just been a real steady force for us in the food program. He's hung in there through some really, really challenging times where we may not have met all of our frequencies with restaurants had it not been for John and one other person really kind of helping to hold down the fort. So John, we really appreciate that. You are a pretty steady, stable presence, not super excitable, not super, oh my gosh, what's going to happen, but we really appreciate that. And again, you do lend support and appreciation for a lot of department-wide efforts, and it's great to have you on our team. So we're glad that you're choosing to spend the latter part of your career with Berrien County with the health department.
Oh, well, thank you very much. And I appreciate Nick and Nikki. I appreciate your leadership during all this upheaval going on. So thank you very much. Yeah, I've been around for a long time. I know this is Board of Health, but I remember, Bill Wolf pre-Beard days. So I go back pretty far. And in PEG, we were on,
Right.
Planning Commission. And so, yeah, a lot of water under the bridge, but good stuff.
Yeah, I really appreciated you've really brought me up so that I understood planning a lot better. I really appreciate that.
I fooled you.
Really
Okay.
dedication to, you know, a board member to learn. So thank you so much.
Well, you're welcome. Thank you, Peg.
Thanks, John. So next up, we actually have Dawn Mitchell, who also has had her 25 years with county, with the health department. So want to honor Dawn. I'm going to turn it over to Jillian, who is Dawn's supervisor.
25 years, Dawn. How is that possible? Dawn,
I don't know. I don't know, but I did it.
you did it. Dawn has been such a stable force and presence at the health department. And it's, you know, a lot of people, when they think about Berrien County Health Department, Dawn is one of the people that comes to mind. I like to joke with her that she literally knows everyone in Berrien County, it seems. She remembers nearly every child that she's ever done a hearing and vision screening for, which I just find astounding. But she'll see them as young adults or as teenagers and say, how did those glasses work out for you? You know, that they got back in first grade. So she really has a passion for what she does. She served as a hearing and vision technician for a long time before she became coordinator for the program back in 2018, and has really done wonderful things with the program. Under her leadership, she has instituted a newer program that you might remember hearing about last year, that is the Vision Exams for Tigers, or VET program, linking students in the Benton Harbor area schools with free eye exams and getting them the glasses that they may need as a result of those eye exams. Really just wonderful stuff, you know, similar to Melissa, and I think this is just part of what Hearing and Vision team is all about. They jump in and help wherever needed. And Dawn has always been one to jump in and help wherever it's needed, whether it's working at the Benton Harbor Farmers Market, or in the case of this pandemic, she's been leading our hotline team of people answering the phone, of the questions that are coming in every single day from our residents and community members regarding COVID-19. One just other fun fact about Dawn that I like to share with people is that she not only has worked at the Berrien County Health Department for 25 years and in this building for 5 years, but she also worked in this building when it was a car dealership more than 25 years ago. So she has worked here twice under two different businesses, and I just think that that's really funny that she kind of ended up back here in this same building. But we're so grateful for Dawn, for your teamwork, your collaboration, your leadership. I thank you, Dawn, for everything that you've done, and especially in the last few months, it has been just so comforting to know that you've got it, and you're leading the hotline team, you're responding where we need you to, and that has been just such a comfort to me, and I know to the rest of our team. So thank you for everything that you've done.
Thanks, Jillian. I know when, you know, I think about, I don't know, I'm getting choked up. When Mike left, he was kind of the last tie to my mom. And my mom retired in 97, I believe. So I just get, I'm thankful for everything that, all the friends I've made and all the things that we've accomplished here. And it's been a tough road the past couple months. Not just that, I got a cousin that's really ill and an aunt that I'm taking care of. So, and it's heartwarming to know that the leadership that I'm under is understanding for those things that are going on within my family. So I appreciate you guys, your leadership as well. I never thought I'd be somewhere 25 years, but I'm really grateful, and I love everything I do. So thanks you guys for being my leaders.
And just to add to some of that, I mean, Dawn is also one of our social directors here at the health department as well, trying to plan different activities or potlucks or things together, Melissa as well. But really, how can we plan some events? How can we plan community events to engage the community? How can we plan some things to engage staff and some of that camaraderie? And so Dawn, really appreciate that about you and your presence on our team as well. So we're really glad this is where you did choose to spend your time, even if you didn't set out for it to be this long with us. We're glad you're here.
Thank you.
Yeah, and thanks for that hotline. I've heard so many good comments about it. Of course, I didn't get around to passing those back, but to have a hotline that's answered responsibly with good information, that's such a gift to our community. Thank you.
So last but certainly not least, we have Ruthie Mcclinton, who is celebrating her 15-year anniversary with the health department. Ruthie is a clinical services client associate, and I'm going to turn it over to Carissa to start us off in talking about Ruthie.
Good morning, everybody.
Morning.
So excited to be able to celebrate Ruthie on this great accomplishment of 15 years. I've only been Ruthie's supervisor for, excuse me, almost 2 years. And just to see how resilient and hardworking she is really inspires me to just be a good person in general. She's been through a lot of stuff this year, and she, upon her coming back to work, she jumped in kind of like she never left. And with the ever so many changes in our department, she's handled them with style and grace. And that's one thing that I can appreciate about Ruthie. Even though we know that change is hard, but it's necessary. And I'm thankful that she's the type of person that really recognizes that and wants to do what she can to better serve our clients, and make sure that they have the things that they need. So I just want to tell Ruthie that I truly appreciate her, on a professional level as well as a spiritual level, because there are things that she has truly helped me with, again, to just be a better person and be able to show humanity to other people. So I appreciate that about Ruthie.
And just to add to that, so Ruthie, I mean, as Carissa pointed out, I mean, Ruthie is such a valuable member of our team. I know there are so many of her colleagues that come to her for how should we handle this, what's going on here, and really look to her for a lot of support and advice. She has lots of knowledge about our programs. When our clients come in, sometimes they're really nervous or are unsure of whether they should be here or in the right place. Ruthie is just such a calm, steady, welcoming presence that she just helps put you at ease. And her coworkers see this, our clients see this. She is absolutely the person that you want being on those front lines when somebody's coming into our department for services, whether it be for the first time or the 20th time. But Ruthie, you've done an excellent job in making those connections, cultivating those relationships, and really being such a good steward and ambassador of our programs and services. So I thank you so much for that. It is a joy to have you on our team.
I definitely thank you, Carissa and Nikki, for those really warm words. I know when I first came, I was a little nervous, didn't know I was going to be here this long, but I actually made it, you know, my family. I can say that we all close and we family. And I think, you know, I just thank you guys for the things that you have done and helped me. And even to just have me on your team is a blessing. So I just thank you guys. And I'm gonna try to do my best for whatever long time I'll be here. And hopefully that with this coronavirus, you know, once it get over and stuff, we can go back to some type of norm. And you know that we can, because I like to kind of hug on you, just say thank you. But with this, it's so hard. And like Carissa said, over the last couple of months, I have been through a lot. I lost my mom and I lost a few of my brother-in-laws and some other people. And, you know, And it's kind of, sad, but I still have that faith to believe that we're gonna make it. We're gonna make it. So
Amen.
I just appreciate each and every one of you, especially for having me on your team. Thank you.
Thank you.
Thank you, Ruthie.
Thank you, Ruthie.
Really appreciate it. You do set a wonderful tone, so it's lovely. And those hugs, they're missed. So. All right, so you will be delivering some certificates. So that would be great.
Just so everybody
So,
knows, if you do have your certificates, I'll be bringing them to you. Make sure you get them. So to commemorate the day.
all right, very good. Thank you so much for your service. We really appreciate it. So,
Thank you.
Thank you, Peg.
yeah.
You're welcome
Great
to
work.
stay, or you can go about your day, whatever fits your schedule.
Mhm. All right, Health Department's financials. Just thank you, Lisa, for every month getting out a good, getting out a report. I'll let you say whether it's good or not, but thank you very much.
Okay, so April statement is, let me review a couple highlights on that statement. Federal and state grant revenues through April are 138,000 under budget. That's about 11%. It's timing of some grant reimbursements. So I expect we'll be, well, I know we're going to be better than budget for the year. We are, last year, the comparative were 270, almost 277,000 under last year. Last year at this time included 250,000 for the Benton Harbor Water Filter Program. Amendments to the comprehensive agreement are going to add 135,000 to our central local public health funding. And we have received notice of 303,000 related to the COVID-19 response. So continuing on sort of down the line in the revenue section, permits and inspections are over budget, 52,000. The budget is an average for the year. Much of our food service licensing happens in the first couple months of the year. So sort of the important benchmark to see there is looking at last year, we're 24, almost 25,000 behind where we were last year. I'm anticipating some of that will be permanent. Some of it's lagging last year, but everything's been closed. So we may make up some of that difference as the year goes on. We are also anticipating in that category a loss of temporary and seasonal food service licenses. I'm estimating that overall impact to be about 30,000 on the year, a loss of revenue. In the clinics, private insurance, Medicaid, Medicare categories, we are under budget 27, almost 28,000 combined, which is about a 31% variance, but we're flat according to last year. The clinic revenues, just because of the timing of when we receive the cash back, it's about a 30 to 60 day lag. So I'm not sure we're seeing the full effect of COVID-19 on the clinic closure so far to date. I'm anticipating we're going to be by year's end about $45,000 under budget in that category. Medicaid Title 19 cost reimbursement through April is over budget 52,000. We receive quarterly payments, so that's basically timing related at this point. The net effect on projected annual revenue is an add of 363,000 over budget. On the expenditure end of things, overall direct expenditures, so before any county services allocation, we're under budget 289,000. Much of that is in the personnel categories. That's about 14% under budget. We're over last year. After I adjust out Medicaid last year, I adjusted out a Medicaid medical examiner and the water filter expenditures. So we're over about 41,000. That's about 2% over last year's spending. COVID-related expenses through April are 152,000. To date through May, we've spent 185 of the 303 that we've received so far. We have not received real specific guidance about additional revenues coming to us. But I will, as we get specific identification of what those amounts will be, I'll reflect them in the projected statements that are also attached to your packet. Personnel related costs are 13% under budget, 243,000. But we are over last year by 83,000. Much of that is on the benefit line, and much of that is related to retirement benefits that have our share has increased year over year. Our current fringe rate, so benefits versus salaries, is 48%. It was 44% last year, but still better than our budgeted rate of 51%. Bottom line, through April, our sources of funds exceed expenses by 55,556. That's an improvement over budget of 289,000. So we're looking healthy through April. So also included in your packet are several fund statements. The combined statement is showing our projected fund balance at the end of the year of 1,186,000. We're projecting our revenue to increase over last year, 194,000, and expenses to increase 133,000. We're attempting to balance current year funding with our COVID response. So we're watching to maximize our sort of current core fundings to maximize those balances while maintaining some of our COVID related funding to date. We can carry it into next year. It has a termination date, an end date of March 15th of 2021. So we're managing our response and our spending along those timelines. There's a couple issues I'm really watching. We have applied for and received approval from FEMA of a public assistance award that will cover isolation and quarantine facilities should that become active. And then there's also some CARES Act funding that's being discussed at a state level. I'm not sure what share of that we may or may not receive. And then looking into sort of farther along the line, what effect COVID, the governor's shutdown will have on county finances, and then how that flows into our finances for next year. So we're trying to anticipate some of those changes. Any questions?
I had a question on the staff salaries being under. Are there many positions open right now, or what's the status there? Does that causes stress?
Yeah, we do have some vacancies. The exact number I'm unsure of. Do you?
Honestly, I think we might only have the temp positions open right now.
We just filled a public health nurse vacancy that's been vacant all year. So we hired a nurse. She actually started last week. So that has been good. I think we've talked about this before, but the salary and the benefit costs are budgeted quite conservatively as well.
So when we go through the budget, if there, for any open positions on the budget, we budget at the highest possible fringe rate, especially related to health insurance. That's the big hitter on that line. So it does appear under budget. If you look at last year, even our budget to actual comparisons generally run under budget by year end. There's some accounting accruals that go through also. By year end, we generally on those lines are under budget, anywhere from 3 to 5 to 8%. I think last year is sort of a better comparison. To kind of watch where our spending. So on the salary line, we're 3% over last year, and you can see the effect of the increased fringe or the retirement benefit on the fringe benefit line. So it may be helpful to look at the combined statement. If you look at the salary and fringe for 2019's budget compared to the preliminary, you can see pretty significant variances. So we had budgeted almost 3.6 million in salary and wages and spent only 3.3. So those numbers are soon to be final once the 2019 audit is completed, but there's some pretty significant variances that we incur on those lines every year.
Just from a staffing standpoint, to also get at your question, Peg. So with this being through April, we didn't have a nursing manager until the end of March. We have had some turnover in some positions where maybe the newer person started at a different place on the pay scale, as happens with government positions. So that also explains a little bit of this. But I mean, surprisingly, because we struggled for so long, we don't have that many vacancies right now.
Good. I always worry, and that's one of the things I always worry about with this much stress. So.
Yeah.
So Wasserman, I have a question. Okay.
Yep.
Yes, Joe.
I've asked Kim online about this, but I was concerned about the upcoming budget and whether we're getting any guidance from the state, for that matter, from the county, as their revenues shrink. I know the school systems are looking at 20-25% cuts. So, I'm concerned about our budget for the health department in the upcoming year.
I haven't received any guidance from the county other than to anticipate that we will more than likely receive some reduction in funding. It's tough to anticipate at this point.
We've been having some conversations with MDHHS and some of the program staff with some of our different programs. And I think there's just a lot up in the air in the state budget as well as there is with the federal budget. I think it is reasonable to expect that there will be some funding that goes towards certain health and human services programming that might be diverted or just won't be available in the next fiscal year. But we really have no indication. There hasn't been any sort of statement like there was to schools about just expect a flat decrease. Those are other things that we are definitely paying attention to, trying to think about what some contingency plans would be if some of our functions were underfunded next year.
Bill, do you have a comment? I'm sorry, you're shaking your head.
No, that's fine. I just wanted to put that in front of the board. Nikki had mentioned that to me the same, but it's just something that I think we need to be concerned about, perhaps, as we approach the next fiscal year.
Joe, it's a great question. I think we're all, as everyone has said, up in the air about what's going to happen. The impact probably will not hit us in 2020, but what comes in 2021 will be very interesting. because a lot of these sources of funding have been spent. So how are they going to be made up? We don't know.
I think it also depends upon what the federal funding looks like. As I understand it, they're advocating for additional federal funding, but whether that's going to be forthcoming or not is unknown.
Some of the tea leaves say that's may not going to happen. As you know, Senator McConnell, in his wisdom, says that state and local governments do not need to be bailed out. And that's been an effective roadblock to even congressional discussions. We'll see.
Right.
See the funds that you brought in for COVID. Do you have any sense, Lisa, as to whether those are covering real costs or any idea? Or Nikki?
That's a good question, Peg. They're definitely real costs, but we have redirected certain staff from sort of their normal programmatic or administrative responsibilities to the COVID response. And so we're saving, if that's a way to look at it, on costs on one side while spending them on another. It's kind of a balancing act. So especially once the world sort of starts getting back to normal, or the new normal, whatever that is, I think we'll see maybe a bit of refocus of our time. We're going to continue to do a lot of contact tracing, so covering staffing on that end, but maybe not sort of the emergency response that we started with. So we're anticipating and trying to, especially with our initial response, we didn't add staff. We basically managed the crisis within our current team. And moving forward, we're getting our feet on the ground and determining what staff we need to continue that effort over longer term.
And just to add to that, so we, in addition to the fact that we have had some staff that have been redeployed to the COVID-19 response from other duties, there have been one or two temporary workers that have been added. We are planning to add more for the contact tracing. And so that will become significant. As we'll get to in a little bit, we're looking to add at least 5 people for contact tracing. We have had a significant amount of overtime. So that has been an extra actual expenditure that wouldn't have been there. And then there have been a lot of supply purchases. There have been some software or smaller technology purchases that we've had to do, some equipment for having some of the screenings that we're doing, and additional PPE, and being prepared for the isolation and quarantine facility that's on standby. So those have been some of those other actual incurred costs that would not have been in place without COVID-19.
Thank you. All right, any additional questions for Lisa on the financial reports? All right, so tell us what's happening.
Yeah, so we're all going to kind of tag team this with what's going on with the COVID-19 updates. I'm going to share my screen so that you can see some slides. We don't have slides for everything, but we do have some slides that we'll share. Let's see if we can get this done. Okay, never know if we can. All right. So we're going to start off talking about some of the data. So we've got some slides about trends. I know Dr. Berthenson had some numbers. You want to get us started?
Sure.
With this data conversation?
Sure. I'll give you a couple things I want to say. Is one is a little celebration thing. You're going to say that later. Or, okay. So from a celebration standpoint, in the last day or so, the state released a new study which showed by county how many tests were done in that county per million. That's the number they presented. And we are the #1 testing county in the state.
Wow.
Which is pretty impressive. We didn't expect that, actually. We knew we were testing rich because Spectrum has been a very, very good partner We were able to get some extra tests with the Sandy Patty concert. Intercare has been important player more recently. And then we worked hard to get tests from the state and get tests sent out. And so has Lakewood. So we known we were testing rich, but we didn't know we were number one. The only jurisdiction that was higher was not a county, was the city of Detroit. They were significantly higher than us. But we had more tests per population than Wayne County and all the others. And some of the numbers actually very surprised me, if these numbers are accurate, and these are the state's numbers, but we tested twice the percentage that, say, Genesee County is, where Flint is. Now, they have had a huge problem on the east side of the state. And considering the history more recently with Flint County, you would think that there would have been robust testing there. And we had twice the testing of them and many other places, out-tested Washington, Hingham, all these other places. So that's a celebration. But it also means we've done a lot of work. When you've done that much testing and come up with that many cases, for the size department we are, that's why our contact tracing numbers are so good. And there's a celebration I come up with that somebody else will present later. So that's how. Now, just looking at our numbers, so congratulations for all our hard work. And you should be proud of these people, really.
And our partners.
Yeah, and our partners, of course.
Yeah.
Yep.
Others that are doing testing.
Absolutely. And then in terms of numbers and stuff, in Berrien County, we're at 53 deaths, unless one happened during the night, I don't know. Of note on those 53 deaths is that 33 of those were patients from a long-term care unit, which is 63% of our cases. And there are at least 2 other cases that weren't from an LTCU that were hospice cases. So you could say that pretty much 2/3 of our cases were hospice and LTCU. Also of note is that our average age of someone who died was 80, and our median age of someone who died was 83. Those are significant higher numbers in the state, which respective numbers for that in the state are 75 and 77. So we're up quite a bit, in terms of it's our older population that has really, had the cases. Also, if you look at Michigan's number, this really, as we said way in the beginning, this really is a disease associated with age. And as you go down by decade, the numbers get lower and lower and lower. So it's significantly less than 5% of the deaths in people are less than 50 years old. So that's a pretty dramatic number. And of course, you saw the median and the average. So in terms of, there's a new study that just came out 2 days ago from CMS, the Center for Medicaid and Medicare Services. And they studied 80% of the LTCU patient clients in the United States. So it's not a complete number, but it was 80% of them. And there were 26,000 deaths among LTCU patients in the United States. And that's just 80% of the LTCU. So you extrapolate that out a little bit in terms of the United States wise, that'd probably be, 1/3 of the deaths from COVID in the United States are LTCU related. So it's not surprising that our number will be where it is. And it's anecdotal, but we do have a robust number of LTCUs. When I talk to other medical directors, none of them have the numbers that we have, by and large. In the United States, there have been, there are in that 80%, there are 60,000 people in LTCUs got infected, and there are 34,000 staff in these LTCUs and 400 deaths in staff beside the 26,000 in clients. So you can see those are pretty dramatic numbers. Of course, we know about the racial disparity, and we have it too, but in Michigan, African Americans are 14% of the population, and they're 31% of the cases, and 40% of they're 40% of the deaths, and 31% of 40% of the cases and 31% of the deaths. Excuse me, sorry. Couple of things from the medical literature I think worth noting there, and these are just peer-reviewed. There's a lot of junky science out there and miserable articles that pop up, but a couple of recent ones that were really very interesting. One is from France, a very large peer-reviewed accepted study looking at diabetes and COVID. And 10% of people who got admitted with diabetes into hospitals in France died within 7 days. which is an incredibly dramatic number. More so than most people expected. We all thought the COPD was going to be like one of the main things in hypertension, but really it is diabetes, and one other thing I'll get to. A third of the people that got admitted with diabetes to French hospitals got put on a ventilator. A third. That is an incredibly big number. So what they showed, they looked at lots of things, including medications people are on and things like that, and hypertension and others. But the things that really showed is that just having the diagnosis of diabetes, and this was type 2 diabetes, I'll talk about type 1 in a minute, but that was an independent risk factor all by itself for a really severe outcome. The other thing from the course was that BMIs also, and it's actually completely stratified. As you go down in BMI, the death rate goes down, the percentage of people who end up on a ventilator goes down. So that was a very big study from France, interesting. Type 1 diabetes was not, nobody in this pretty big study, there were only 4% of the diabetics that got admitted, but none of the type 1 diabetics died was on a ventilator, which I thought was interesting. That's a small number, but we haven't really seen type 1 diabetes in Michigan and the United States being a main issue. I thought that was an interesting study about diabetes. A second study I think that is interesting, it was just done by Harvard, came out of Cambridge, came out yesterday, and it's looking at sort of some old data that gives us an inkling what we might expect to see later, and it looked at the effect of ambient temperature and what effect that has on COVID rates and deaths in areas. And it did show that there's a modest relationship, and this study just went from January 22nd through April 3rd, and just look at ambient temperatures over 50 degrees, and as the temperature changed, what happened? And it showed a decrease in infection rate, and it showed a decrease in serious illnesses and deaths associated with temperature, and that was peer-reviewed and accepted. There is a big ongoing study now to see what happens when temperatures in communities go over 70. And many people have mused when you look at Miami, Houston, Phoenix, San Diego, warm weather cities that have demographics, some of the cities up north, why haven't they been blasted or even come close to what cities like Detroit and New York and Boston and Philadelphia have happened? And many people are musing that is really an ambient outside temperature phenomenon. So I thought that was interesting. So as you know, lastly, as you know, antigen testing started with a stuttering in the United States due to problems with the CDC's testing and stuff, but that started in January. But antibody testing has been going on for a while now. It's still very problematic. No one knows which antibodies that are created by coronavirus are actually protective, nor do they know how long they last. So those are two really, really important things. And this is at a point where we'll be talking about businesses and as they open up later. So this is just a little setup for that, is that a lot of businesses now are really looking for immunity tests and proof of immunity, and that is very, very problematic. So the things we can look to antibody tests for is surveillance activity can tell you what's happened and what's gone on in your community. When most communities that have been looked at and hit by COVID, it's only like 2 to 3% of large communities. And then in some places like the Bronx, New York, it's been like 20% or things like that. So the numbers are not that outstanding in terms of how much. And until we get to a herd immunity of 50 to 60%, you don't really have a huge protective effect from that immunity phenomenon. So we're a ways from that. The second thing where antibody serology is potentially valuable is just to help some people know that they've sort of had, just for dealing with their own family, it might be helpful. But it's no sure thing. And the problem is even the best of the serology tests, and at the current moment, only 10 of them are actually really certified and approved. And like I said, there's still problems with them. But of those 10, even with their best sensitivity and specificities, if you were to test 7 people trying to prove that they had immunity, for every one you found, you'd find 6 that were false positives based on a current, 1 to 2% in our population. So that means that 6 out of 7 people would have some false belief, or their employers would, that they're actually immune when they're not. And that's a very sobering number. So we've been working on, we'll talk about that, trying to help people to understand that this is not a panacea or way to try to run your business by whether or not you have people that are immune. And so with that, I will stop. Thank you.
Thank you, Dr. Gray.
Yeah, just one clarification. Did you say 60 or 50% herd immunity?
60% is what most people think for most, and most people believe for this too. That would be a point where there's so many people that are now positive, it's very hard for there to be the spread from contacts.
Thank you.
This is Joe. The length of time for immunity, do they have any, or did I miss?
6 to 7 days, almost every one of the antibody tests show a significant jump in the IgG.
Yeah, but
So
if you have
that's,
does that protect you and for how long?
so I couldn't quite hear that.
Oh, if you have the antibody, how long does that protect you and how long would it protect you?
Yeah, so that's the question nobody knows. At 80 days out, some of the antibody levels are starting to drop. What that actually means, nobody knows. That is yet to be determined.
Doc, this is Ray. I got a quick question. Did I hear you correct mentioning that there are multiple different antibodies that are produced? And whenever they're looking or screening, testing for antibodies, is there a particular one or just looking for something that's a coronavirus antibody?
Since they don't know yet which one is the best predictor of immunity, that several have gone down several different tracks and doing different tests. And time will only tell which is the one that really is the best. And part of that will be part of this is helpful for the blood plasma donation program, but it's also helpful in vaccine development in terms of there's multiple vaccines being developed, as you know, and which one will ultimately be which ones will be the winners, there probably will be multiple ones, will in large part depend on which ones targeted the antibody systems that are the most protective. Does that help?
Okay, thank you.
I have a
Yep,
question.
thank you.
Doctor, among the people who contract coronavirus, has there been a decrease in the number of deaths, or has anybody looked at that?
We're going to show you some nice slides of how our trends are going. There's one other thing I didn't mention earlier, which I meant to, is if you look at our 53 deaths, every single one of our 53 deaths has at least 2 comorbidities, diabetes or hypertension or elevated BMI or COPD or something. Every single one has at least 2, and more than half have 3. Those are very sobering numbers when we look at, how is public health affecting people upstream, but those are dramatic numbers.
This is Joe again. With that, then it would seem like it would be prudent for people in that category to continue to self-isolate.
That is exactly my message, is for the most vulnerable, trying to tell them both on age and those comorbidities, they're the ones that really need to be staying home when possible, masking when possible, masking period, et cetera. That's the group that really need to work on.
But I want to add a layer of complexity to that. It's not just that simple, because as businesses reopen and as we've seen in our behavior risk factor survey, diabetes, hypertension, obesity, asthma, all cardiovascular disease, these things are fairly prevalent in our population, and not all of those people are retired and don't work. So as businesses start to reopen, it's not necessarily an option for everybody who has this vulnerability and susceptibility to stay home. Now, with age being a factor, and as age increases, the likelihood of being forced to go out into the workplace decreases. But it's a little bit of an oversimplification to say, well, anybody who has these underlying conditions and vulnerabilities should just stay home.
But I'm not making that oversimplification. People who have to go to work are going to need to go to work, but maybe they're the ones that are not on the front lines in business X and move to a different position, or the ones that will always for sure wear a mask and be extra careful and make sure they have hand sanitizer to do the things they can.
Yes.
I have another question. This is Joe again. I was just curious that of the 53 deaths, and you said I think 33 were in some kind of long-term care facility. I was curious as to how you count the death. Somebody asked me this question. I said, I don't know. If a nursing home patient, do they have to die in place, or if they get transferred and subsequently died in a hospital, how is that counted?
So if,
So most have died in the hospital. Some have died at home during the night.
Okay.
but if they're a resident of a long-term care facility, whether they're hospitalized or not, we count them as a resident of a long-term care facility.
Okay, yeah, thank you.
But that is, and that's interesting. I think that's the way it should happen.
Yes.
Because that's where they got it. However, the state of New York does not do it that way. And they divide them by hospital deaths and LTCU deaths. And they would count somebody, which would be 50% plus of ours, who end up in a hospital. They count them as hospital deaths, which is problematic, for sure.
Doctor, is it possible that there is different strains of this virus? Because like in New York, it seemed like people were just dropping dead like, flies, but I don't know. Some other places we have, like here, for example, we have deaths, but they're not so pronounced. So I was just wondering, is there more than one strain? Is one strain more virulent, or has anybody looked at that?
That's a great question that has very much been looked at way from the beginning. Like, does this virus mutate? Like flu virus, for instance, mutates quite frequently, even during one flu season. Oftentimes there's another strain, which is in one area of the world, or one area of the country, or sometimes even one area of the state. And it changes throughout the course of even a respiratory season. But this particular virus has shown very, very little change and no substantive changes from area to area. And most people don't think any severity differences from area to another area is because of the difference in the virus. It's the differences is in the demographics. So New York City had huge high population density, a probably raging number of cases before they even knew it, and it was really there, mass transit, packed apartments, et cetera, and lots of comorbidities. So almost everyone would believe that is the reason. It's not because of a strain difference at all. It's been remarkably steady, which is also, however, good news in terms of whenever the vaccine is developed, that it doesn't appear to be some kind of dramatic moving target. So that's good.
Dr. J, I have a question about, will future data analysis kind of show that this virus, kind of most of what it did was shorten life by a year or two, given the average age of death?
Well, the average life expectancy in Michigan is 77, so you can make your own interpretation for that. I mean, are young people would be hit? Yes, but pretty rarely.
So I want to move us along. We do have some other slides and some other things we want to make sure we cover, but I want to make sure we continue to have some good discussion. As Dr. J said, we do have some slides here that just show trends. So this is an epi curve showing the confirmed cases for Berrien County residents. This is organized by their date of symptom onset. So you'll see it does go back to early March, because although it was mid to late March when we had our first case here in Berrien County, going back some when people say this is when my symptoms started during the case investigation, that's what we're using here. So you can see there has been a lot of variability. When we got into late March and early May, that's when we're seeing a bit more of this activity. But some of this, it's hard to read a whole lot into the confirmed cases because this is a reflection of testing strategy. So to Dr. Johansson's point earlier, we have had a very robust testing environment compared to other communities. We still have had a very limited supply, so that makes me feel a lot of pain for these other communities that have been that much more restricted on who they can test. But just because somebody shows up in this graph doesn't necessarily mean that there weren't more out there, or, I mean, there's variations. We got a lot better at expanded testing a lot in this area, so it's hard to say if this is really a reflection of increases in transmission or that we were just doing a better job of identifying cases. But this is the overall trend. You can see that we do have a little bit of a decrease here. However, towards the end of this sort of epi curve, especially when we're using date of symptom onset, you expect there to be a little bit of a lag, and in the coming days, those numbers might come up a bit. So another thing that we're really looking at, there's a few different data points that we've been really looking at in terms of identifying reopening, but then also trying to take together to look at how is transmission going in our community. And one of those is the percent positivity. So of all those tests that we're doing, what percent are positive? And ideally you want to see, even as your number of tests is going up, you want to see the percent that are coming back positive going down. And you can see going all the way back to the middle of March, we have a decreasing trend. And even more so, like through the month of May, we've definitely seen a decrease in the percent of our tests that are coming back positive. So that is encouraging. That is going in the right direction. We're also looking at hospital admissions, inpatient census at the hospital. And this is showing the census. So it's not, this graph doesn't show all of the admissions and discharges. So if somebody is there for 2 weeks, they're going to be on this graph for that whole 2-week period. But even so, we've seen the census of COVID-19 patients at Spectrum Health Lakeland really decrease here towards the end of May. We were at some higher levels here in mid-May. Some of that was related to long-term care facility patients or those from some other facilities that maybe needed to go into long-term care facilities and there wasn't a place for them to go. So we did have some extended stays, longer than might have been warranted for care. If we were having a really large number of cases, that would have created a bottleneck that would have been problematic, but it was managed okay here during this month. But you can see we've had a pretty significant decrease in the last week to 10 days of the COVID patients in the hospital, and that's really encouraging. And what I'm hearing from our other local health department partners in the region, their hospitals are experiencing the same trend, and they're even at some of their heights, their higher areas were not quite as high as ours. So regionally, this is looking really good as well. And this is a graph which has, just because it is lower numbers, as Dr. J said, we've had 53 deaths in our community. So showing this graph by their date of death, there's a lot of variability. There's a couple of days where we've had just a higher number of deaths. And a lot of this is related to transmission going on in long-term care facilities and those 63% of deaths from long-term care facilities. We are seeing a little bit of an upward trend if you look at the whole trend, but this matches what we've seen. So when we saw in our confirmed cases, we had a little bit of a peak, and then 2 weeks later, you have that peak in hospitalizations, and then a week or two later, you have that peak in deaths. So there's a little bit of a lag between all of those things, but we're seeing similar sorts of trends across there. As we have seen the other the percent positive and the confirmed cases in the hospitals going down, we do expect that there would be a similar decrease coming in our deaths in the next week or two. So those are some of the trends. I do want to point out some other dashboards that exist out there, remind you of our Berrien County dashboard. So this is available on the county website as well as the health department website, where you can monitor these things. It's updated daily at 3 p.m. I think many of you, I've gotten questions from some of you, I think many of you are paying attention to this, but within each of these kind of tiles here, there are multiple tabs that you can scroll through to get additional information as well. So just wanted to make sure you're aware of that. Also, I guess it's been a week and a half, 2 weeks now since the governor's office announced this My Start Map dashboard that shows different risk phases that correspond with the My Safe Start plan that the governor put out. So you can look by region, and then within region, you can look by county. So these are things that, these are tools that are out there for the public. There is a back end place or another login portion of this portal that health departments have access to that has a tiny bit more information for us to be able to use. But this is really great to be able to at least look by region and see how things are going or compare to some other counties. As the governor has now declared everyone to be in this phase 4 and has done reopening per her executive order, I think 110, this dashboard will continue to be used for reopening of other things that are not yet open, but as there are many things that have reopened, this was some of the data that was used to drive that decision, or that's what we've been told. So wanted to remind you of those dashboards. I do want to shift gears a little bit now and talk about contact tracing. And Guy and I haven't had a chance to really plan all of this. But just to give you a bit of an overview on contact tracing, I'm going to invite Guy, who's in the room, you probably can't see him, to jump in at any point. One thing that I want to distinguish as we talk more about contact tracing, there seems to be a lot more just cultural consciousness around this public health activity. Case investigation and contact tracing are two sides of the same coin, but they are different functions. So case investigation is a really in-depth interview and information gathering on somebody who is a confirmed COVID case or a probable COVID case. And during that case investigation, close contacts are identified. And so that becomes part of that investigation. There's lots of other information that is identified during that. There's lots of education that happens there. Case investigation is a function that at the health department we are choosing remains with a nurse, and that a nurse is really best qualified to be able to provide that health education information, ask those questions, answer any questions, and do that investigation. And then contact tracing is the next piece, where then the contacts that have been identified through that case investigation then have follow-up. And somebody reaches out to those contacts, asks them questions. If they end up being symptomatic or meeting the criteria for being a probable case or become a confirmed case, they then get moved into this case investigation process. So I know when we've talked about contact tracing before and others have, sometimes that all gets blurred together. That distinction is not necessarily most important, but when we're talking about who's doing the really intense follow-up with COVID-19 cases versus who's tracking and monitoring isolation and providing some a little bit more basic health education towards those who've been exposed, there are some meaningful differences there, and there's a little bit different skill set to underlie both of those activities. So as we mentioned last month at our meeting, we had roughly 9 FTEs working towards both case investigation and contact tracing alone. Based on CDC guidelines for a population our size, we should probably have 22 FTEs. I think that's a bit high based on how we've been able to manage thus far, but we do have 5 temporary positions posted on our website, some as public health nurses to be able to assist with case investigation, and some that are a position titled disease intervention technician, and that is doing the contact tracing portion of things, does not require a nursing background. So we're working to increase those staffing levels. We're also just trying to continue to figure out how volunteers fit into this mix. There have been a lot of people who have said, oh, I'd like to volunteer, I'm willing to commit, or maybe, you know, my whole team who's not working right now could volunteer to do these things. Because there is some HIPAA protected information here, because there is some technological interface on our health department network, we're still working through what a lot of those nuts and bolts are in terms of how volunteers fit, and just continuing to try to assess as more things are opening up. We are starting to see more contacts per case, and I expect that will grow. But we're in a continual assessment mode of really determining how long is this taking and how many FTEs do we need. We don't want to way overstaff and expend resources that we may not need to, but we want to be able to quickly gear up and respond if we do have a big cluster that needs to be investigated and results in lots of contacts, and we have those. So we're building that up, I think, in scalable fashion. We're not going, you know, put the gas pedal to the floor immediately, but working on scaling that up. And that's becoming increasingly important as some of our health department services are resuming, and some of the nurses and other staff that have been assigned to these duties are in part taking on some of their regular roles and responsibilities as well. So continuing to put that together. The team collectively makes 200, 300 calls per day. That's correct, Kat? And at any given time, maybe we have hundreds of people that we are following. We are exploring different technological options that will allow, that will automate some of that follow-up for people who are lower risk and asymptomatic contacts who are at lower risk, that maybe they receive automated text messages instead of a phone call every single day. But we're working through what that looks like.
Where did you get those? Just a quick question. Where did you get those FTEs?
So we've had a team of 4 public health nurses that are generally responsible for communicable disease investigations. They've been spending 100% of their time. And that's a team of 5. One position has been vacant, so that the 5th position was filled last week. So that's our new nurse, so she's becoming acclimated to that. We also have assigned full-time 2 of our NFP nurses to case investigation and contact tracing. And then we've had some other staff members. We have a nutritionist, we have our my case manager, we have our community health worker from the HIV program, and one of our health educators that have been trained in doing the contact tracing portions of things. So they are doing that part of their time. They still have their regular roles that they're doing. And Lakeland has actually loaned us 4 nurses, mostly full-time. The amount of effort varies between probably 3.0 FTE to 4.0 FTE each week. But those staff have been on loan to us. As the health system is coming more online and resuming their activities, those staff are starting to get redeployed back to their more normal responsibilities. So that's starting to fade out a little bit, but we're still in that conversation. We may be able to identify some non-nurses that could help with the contact tracing portion of things. So we're continuing to evaluate, but that's how we've been getting through this function so far.
Nikki, a question. Have you all tapped into the people like school health nurses and church nurses, people who probably are underutilized right now, but might fit your qualifications?
Yeah, so the parish nurses tend to work for Lakeland, and that's been a Lakeland program, and that has been some of who they have deployed here to us. And they're making some of those changes and bringing some of those activities on board. So that's part of who's coming out. And the vast majority of our schools do not have school nurses anymore.
Okay, thank you.
I was reading, Nikki. I can't remember all the details. It was either Harvard or Yale who were offering a training program for contact tracers, and it was free, and it was teaching people, how to go about doing that. And I'll send that information to you when I find it, and because that might be something that may fit in with your plans, that people could have some kind of training on how to go about doing this.
Right, and we're somewhat familiar with some of those trainings, and so with resources available to us, we've actually developed a pretty good training mechanism. So we've got that in place. Please go ahead and send that along if you've got it readily at your fingertips. But we're working through that. Some of the training also is on documentation and how do you document that. And that's something that is hyper local as well. But the skills of how do you build that rapport and get that information out, yeah, that's really important.
This is
Guys,
Joe. This is Joe. Did you ever consider using volunteers, retired nurses or other people who might be able to assist you?
So we're working through, we're working through the process of what volunteers could look like and how they could fit into the workflow. There are some hurdles just in terms of technology and HIPAA and liabilities and dependability. And sometimes managing volunteers, if they are not going to be somebody who's going to show up for 3 days a week for the next 7 or 8 months, sometimes managing that in and out and where people were, and that can be a bit of a challenge. So we are assessing our current workflow to see if there are ways that we can change it that would more easily accommodate volunteers if we're able to get over some of the HIPAA protections and technology policies we have in place for that. So one thing I do also want to show, and then I do want to give Guy a chance, just if there's anything to add to this whole case investigation contact tracing. This is Berrien County metrics. We are represented in the green lines on those graphs compared to the state of Michigan. And the state is putting in place both case investigation metrics as well as contact tracing metrics. This is showing just case investigation, but showing how different counties are performing compared to the rest of the state. And I'll draw your attention to the box down here, but you can see Berrien County is dramatically outperforming the rest of the state in terms of attempting or just getting started on the case investigations the day the test results come in, completing the interview for the case investigation in that first day, the number of contacts that are elicited, and referred cases having race and ethnicity documented. So we are definitely doing an outstanding job. This does reflect the really hard work that our team has put in. And I would argue that in some of these areas where we're not at 90 or 100% even, it's mostly because we are unable to actually contact the individual, not due to a lack of effort on our part, or we have had some cases where we've been getting lab reports that have had a name and that was it. And so we've had to hunt down a phone number and try to identify who that person is. So really proud of our team. It's a tremendous amount of effort to ensure that this really important task is done with a high degree of quality. Guy, do you want to add anything to this about contact tracing?
Yeah, I think these numbers are a great representation, and it reflects just the hard work that Donna Payne and her team, Erica Mueller, Kim Bell, Allison Harper Dutfield, and Karen Quartervine have been doing as the public health nurses. Erica has been training a lot of the people. She has kind of taken the state's resources and melded it kind of with some of our resources to come up with a really good training program to get our nurses, our contact investigators, and our case investigators both updated on how to do this. And we've been doing a phenomenal job to the point, you know, even where we have found errors in the state system with reporting names and addresses and things like that. We found it first, we told the state to investigate it, and we have found errors kind of in reporting processes that way. Overall, I do want to say our nurses are typically leaving by 5 every day. So we are not working extra hours during the week. We're still able to manage the amount of work we have per day. We are working just about 7 days a week though. When new lab results come in for a COVID positive on a Sunday, one of our nurses does come in for a minimum of 3 hours to do just that initial case investigation, get some of the contacts, and then we'll do the majority of the work the following weekday to actually reach out and talk to all those people who might have been in contact. I do have to say our testing strategy, I think, is very, very mature in how we're doing it right now. The nurses are the case investigators. They actually call the people up, investigate them, ask them who they've been in contact with. Then anybody who's been in that close circle of contact is going to be recommended for testing. And we're using, there isn't perfect data out there that tells us exactly when to test an asymptomatic person, but there is enough data that tells us when to not test them. So we recommend that at least 4 days after somebody has been in contact with a confirmed COVID positive, that they go and get tested for COVID-19. And that has been working really well. We have been able to kind of have a short duration where maybe people don't even have symptoms yet. They're getting tested, we're identifying them before they are even at the highest risk of spread. And we're starting a mitigation effort and a quarantine or an isolation really before that person has been exposed to a lot of people. So I do think contact investigation and case investigation is very, very beneficial, and I think we've been home running it. We've been hitting it out of the park. So.
And just to be explicit in what Guy was saying, because I know the board is worried. So our team is working 7 days a week. We have built a schedule so that we don't have individuals for the most part working 7 days a week. Still working on Donna, our nursing supervisor, to try to clear her out of this a bit more. But the team has been really dedicated. They've been very willing to work on weekends and odd days. So we're really working through this to try to manage this, still try to get people out of the office when we can to make sure that we're not driving them straight to burnout, because we're in a marathon. We might be at mile 6 right now. So at least in terms of case investigation and contact tracing. Maybe we're further along, I don't know. So that's really the visuals that we have for you. So I'm going to go ahead and stop sharing. We do have a couple other things to talk through.
Excuse me, Nikki, I'm cognizant that it's 9:26. So.
Okay. One thing I think it would be important for us to share, and we'll keep it to 2 minutes, but we heard from Dr. Johansson about long-term care facilities and how they are really, they're very significant in our community, and that's where our most vulnerable population are living, and it's a vulnerable setting. So we've been really trying to figure out how do we better characterize what's going on in these community or in these facilities. How do we understand this? So Guy, in collaboration with a colleague at South Lakeland, has really developed a protocol for us to do some long-term care facility surveillance, to where there will, I think starting either later this week or into next week, the long-term care facilities will have access to a small number of test kits and testing supplies, so that on a weekly basis, they will be providing a sample of their residents and staff. They'll be collecting specimens on them, and we'll be able to get that data from all of our long-term care facilities, instead of just doing mass testing in one facility and that eating up a significant proportion of our testing resources in our community. We'll be getting bits and pieces of information from all of our facilities. That will give us some really good information about not only what's going on in those facilities, and potentially catch some asymptomatic carriers before transmission gets way out of hand. It also does give us some insight to the community, because the staff there are out and about in the community as well. Got anything to add to that? So we're doing a lot of effort to make sure we're protecting our most vulnerable here.
I would just add that we have been doing this surveillance
Absolutely.
all along
Yes,
from the very beginning. But in the beginning, we would go in with, when we had to test 5 or 6 tests, and test the, test the roommate and the staff that were involved, whatever. Now we can do ongoing tests where a larger facility, for instance, might get 40 or 50 tests a week to test this hallway, this group, wherever. So several of our long-term care facilities now, pretty much almost everybody, has been exposed and had it. I mean, that's also true of a couple of our places now, so.
What does presumed positive mean exactly? I'm not sure.
Right, so that essentially means that somebody who has all the symptoms and they have a connection, some sort of contact with somebody who is a confirmed COVID case, but for whatever reason, they were not tested. The bulk of our presumed cases happened during the time when testing was not readily available. And so people who were not seriously ill weren't tested. I think when we started measuring that or reporting on that category, we were at like 140 cases. We've added relatively few to that, because as people are presumed to have it, they're being tested and either become confirmed or not a case.
So many of those were like, there was a positive test, and then another member of their family has a fever and a cough. We didn't have the testing to go and test them. We presumed they had it and told them to isolate and quarantine them for the right period of time too. And that was very logical and wise for that moment.
Okay, thank you.
I've had a request from the staff to end this meeting about 9:30. Are there any burning questions before we end this public meeting?
Well, I really got one I'd like to ask. How are we working with schools as they prepare to reopen in August?
We're closely. So
Okay.
Dr. Johansson and I have been in pretty close contact with local superintendents. And some of this, I'm also have been assigned to a statewide work group to represent some public health interests on how schools should be opening and writing that guidance. I think the state has a goal of getting that guidance to schools in July. So
Right.
we've been doing a lot of work locally. We're trying to influence things at the state level as well.
A lot of the schools now are actually reaching out to their people too and presenting them with some options and asking them to weigh in. What would you feel comfortable with, which is interesting. But a lot of schools are doing that right now. Quite a few of them.
Peg, quick question for Nikki. Nikki, are you making a report to the Board of Commissioners tomorrow morning like you have been?
Yes, it will be fairly short based on the agenda, but yes.
Okay, great. Thank you.
Anything else? Any other questions? I know I'm rushing you and we could have had a much more robust discussion, but it's nice to start with the facts, the well done presentation.
I will ask Jillian if we received any comments from the public or questions.
There are no public comments at this time.
Okay.
All right. Thank you. Then we are adjourned. Thanks for the excellent job everyone's doing.
Thank you all very much. We appreciate your support.
Thank you.
Stay safe.
Bye-bye.
Bye.